Now, facet joint violations come in many varieties, and the literature has been done a pretty good job over the past 10 years or so in trying to grade the types of violations. What we don't have now is a good bulk of literature that clearly defines what type of violation is going to give you each specific outcome and how it's going to subtract from how a patient perceives their outcome in a variety of different time points. Obviously, there are a ton of different variables that go into this equation, everything ranging from the patient to the patient's own anatomy to the patient's sagittal anatomy, et cetera. And so I don't know if we'll ever have that data, but we do have some good data to suggest that, in fact, when we do violate the joints at the superior unfused levels, it does have a pretty bad outcome with regard to the patient. And this is just an example showing two different patients. And this is an example up on the left-hand side where the joint on the patient's right, again, looking at the left panel, but on the right side of the patient, the tulip of the pedicle is roughly in the right spot. You want to be at the junction of the transverse process and facet when you're inserting your pedicle. However, on the patient's left, again, looking at the left image, we see that it starts to abut the lateral border of the facet joint, which is in part a facet joint violation. Whereas you go over on the right side, the right image, you can see that the screws are in fact going right through the joint themselves. And this is something that unfortunately we see, I wouldn't say I see it every week, but I see it enough times. And not only does it have an impact on the patient, but it has an impact on diagnosing a patient who has this in conjunction with perhaps a couple of different pathologies that you're trying to diagnostically figure out where the patient's pain is coming from. Because typically when you have a facet joint violation, it doesn't necessarily mean that the patient's going to present with overt instability. However, they do oftentimes have a variety of types of mechanical type of lower back pain that potentially could be related to the facet joint violation. But I think in a quick summary, when we looked at the bulk of the literature on this, we know that rostral facet joint violations pose real risk. We know that there are higher rates of adjacent segment degeneration and disease. We've seen that in our own patient population. There's lower quality of life outcomes, which I'll show in a few moments. There's higher pain scores. There's higher rates of resource utilization, how many times a patient comes back for imaging, whether it's x-rays, CT scans, CT myograms, MRIs, physical therapy, facet joint injections, all types of things that in total put spine squarely in the crosshairs of payers, but also if you just think about our mission to improve patient care, it subtracts from that very mission of what we're trying to achieve every day. And finally, it oftentimes will result in more revision surgery, which I'll show momentarily. Now, the reasons for facet joint violation at the unfused level, at the cranial aspect of a construct, really comes down to surgeon error. I put it as 1, 2, 3 because really, I mean, these things are avoidable, and it really depends on a lot of factors. A surgeon's perception of what they're seeing in real time, a surgeon's own ability to reconcile what they're seeing with their own clinical surgical skill set. And it also has to do with a lot of other things. How big the incision is, what's the depth of the patient, can you truly get lateral enough, are you limiting yourself? And so there's a lot of different reasons why a surgeon could be off. At the end of the day, items 1, 2, and 3, it really comes down to surgeon error. This is just one study, and I'm going to go through several different studies that basically summarize the previous couple of slides in terms of what a patient can count on if you violate the cranial facet. This came out of Dr. Park's work. This was looking at cranial facet joint violations by percutaneously placed pedicle screws adjacent to a minimally invasive fusion. And this was retrospective, 92 patients, 184 cranial levels, including 92 patients. These were fluoro-assisted. And so they were using a fluoro-assist and both the AP and lateral plane to help them guide their approach. And what they showed is that there were 50% of patients had violations, again, at the unfused levels, and 31 of these joints were in fact violated. And so these, in the images there showed from that paper, just a couple of examples of how that occurs, but this is in line with the images that I showed you before. Yet another study by a different group looked at rates of upper facet joint violation on MIS perc screws and compared to an open instrumentation. This was a comparative cohort study. And what they found is that looking at robotic surgery, it had the least amount of facet joint violations at 7%, 8% for the open group. And believe it or not, fluoroscopically assisted percutaneously placed pedicle screws had the higher incidence. And you would ask yourself, well, why would that be? And I think part of the reason is there's differences in techniques in terms of how the AP and lateral fluoro is utilized. When I used to place these with fluoroscopic guidance, I would have an AP in one plane at the same time. And so if you're going between AP and lateral, it introduces the possibility that you're going to make a mistake with regard to your placement as a potential reason. This is another example looking at the comparison of rostral facet joint violations between robot-assisted percutaneous pedicle screw placement and conventional open fluoro-assisted. And again, looking at 50 patients in each group. And what they found was that in the robot-assisted group, there was a substantially less rate of facet joint violations compared to fluoro-assisted. And so I guess what these papers show is that, number one, these things are occurring. It seems to occur more commonly with fluoro-assisted percutaneously placed pedicle screws, but it is a common occurrence. And if you look at the literature, there are a lot of publications indicating that this is probably an underreported phenomenon. And I think everybody on the call, speaking to the surgeons, we probably have seen this in our own practice, whether we made a mistake ourselves or whether or not a patient was referred to us with the same problem. This is another retrospective study looking at 240 patients that we did. And the whole goal of this study was to figure out whether or not these types of facet joint violations had any impact on the quality of life and other outcomes that a patient would perceive at a 1 and 2 year follow-up. And what we found was that looking at the 1 year follow-up, the quality of life image metrics that we looked at didn't show any difference between those that had violations and those that did not have violations. However, at the 2 year follow-up, we found that the EQ5D, which is one of the validated functional outcome measures for spinal surgery and other types of care, demonstrated that there were in fact differences that were far in favor of patients not having facet joint violations. So in other words, patients who had facet joint violations perceived their outcome to be inferior when we appropriately matched the patients according to comorbidities, the surgeries performed, et cetera. We also then looked at the reoperation rates between those that did and did not have facet joint violations. And what we found was that there was roughly a 2 year, again, looking at the second row down here, there's roughly a 2 times the rate of reoperations in patients who had facet joint violations, a variety of different grades. And so what we found through an independent or a risk analysis is that facet joint violation was indeed an independent predictor for reoperation and the decreased quality of life in our cohort of patients. And this is somewhat intuitive. It clearly matched, I think, what we were seeing for years in patients that were sent to us, but this was just an example of a study that was done specifically looking at the quality of life one can expect after this type of violation. This is another example of a patient of a group that looked at MIS versus open T-lip surgery. They included 225 patients, 450 cranial screws. Again, 1 level T-lip, open versus MIS. And they got CT scans postoperatively to evaluate iatrogenic facet joint violations. And the picture there just shows the manner in which they did it. They broke it up into quadrants. They measured the facet joint angle. And what they found after a careful grading system that they use an independent grader for these types of facet joint violations was kind of an important finding. They found that the MIS surgeons had a higher incidence that was statistically significant compared to open surgery, 41 to 30%. There was a higher incidence of high-grade violations in the MIS group. Again, I think this speaks probably to surgeons just not picking the right starting points or misinterpreting what they're seeing on the imaging. I remember seeing a video that was promoted by one of our major spine companies in North America for percutaneously placed pedicle screws. And the image literally showed the surgeon in the unfused segment going right through the joint to place the screw. But that was probably 12 years ago now. I think we've come a fairly long way, but nonetheless, I think it still occurs on a reasonable basis. We then did this particular group then did a bivariate analysis and found that patients less than 60s, obese, placement at L4 for some reason, right-sided screws versus left-sided screws had a higher incidence of facet joint violations, and patients who had a large body habitus. Again, going to my point, of the depth of the wound, making sure that your incision, if you're going to do it through an open approach, is long enough so it doesn't put your approach too vertical, is also an independent risk factor. So in summary, facet joint violations occur at unacceptably high rates. This is clearly an avoidable phenomenon, and I think it really it speaks to the need for us to not only understand the anatomy, but also to be able to translate what we're doing in the operating to our understanding of the anatomy and to what we're seeing in real time, whether it's through an MIS approach or through an open approach, and whether we're using freehand technique or fluoroscopically assisted surgery. And I think the literature has been pretty clear in terms of what it results in if you violate the superior facet joint. And that includes adjacent level degeneration, higher reoperation rates, lower quality of life outcomes, and higher costs for the patient in terms of resource utilization post point of care.